so alone, left in the corner of this room. I've been sat here for days like this. I hope someone comes in soon. I'm having to live through my biggest fear, that I'm just another problem of a misconceived idea. How could they ever know? I guess it's not their fault, they've given me a home. But all I wanted is a little bit of luck, and for someone to walk in while I was ringing and pick me up. I'm just an NHS England general practice phone. There's nobody here to answer me. I'm ringing, but I'm all alone. 240 million buys a lot of champagne for telephony executives, but there's not a single pound for any more receptionists, so I've got no one to pick me up. I guess I'm here, I'm stuck, I'm just an NHS England general practice phone. An NHS England general practice phone all alone. It's officially the fastest I've ever written and recorded a song. And it's going to have to do because we're out of time. It's 2 o'clock on Friday, the 12th of May, 2023. And we better get started with the Hot Topics podcast. Welcome to the Hot Topics podcast from NB Medical. Neil Tucker here to see you through the next 30 minutes or so on the latest news and research relevant to us in primary care. And this episode, there is a big focus on allergy. There's a good chance that you may suffer from some allergies or someone in your family may suffer from allergies. And it's that time of the year where things are really kicking off. Right now, every morning, my 6-year-old son is waking up. He walks downstairs, gets to the kitchen table, and then his face explodes all over it. There's kind of green slugs of snot just on the table, in the cereal, all over his face. We're desperately left trying to scrabble around, finding some tissues, which we ran out of days ago and really needed to go to the shops and get some more. I even had an email from my older son's teacher this morning saying, does he take antihistamines by any chance? He had very red and itchy eyes over the last couple of days. Ah, the indignity, having your child's school teacher point out how to provide decent medical care to your own children. Come on, Neil, please try harder. Anyway, it feels timely that we have the next in our series of Just One More Thing interviews, and this time it is with Dr Matt Doyle. He's the chair of the Primary Care Committee of the British Society for Allergy and Clinical Immunology. So we'll be having a chat with him later about everything that we need to know about allergy. Meanwhile, we have a new paper in the New England Journal of Medicine, which is focusing on early childhood treatment of peanut allergy, a new method to do that, which is quite interesting. And we're going to have a look at a BJGP paper on prognostic factors for persistent fatigue after COVID in the community. But first, the news. And I know in the last podcast I was saying about how it feels like things have been, just a bit difficult. Everyone's been feeling a bit down in general practice. And on the podcast, it's difficult to find really positive things to talk about. Well, thank goodness we've now got a primary care recovery plan. Just when you thought things were dire, no, don't worry, we've got a plan. And it's not just any old plan. It is a plan from the very top. This is the Prime Minister's Primary Care Recovery Plan. The good news is we are all saved. So it's quite interesting looking at the government website to see the spin that they've put on this. So we are cutting waiting lists. Fantastic. We are getting rid of the 8 a.m. rush for GP appointments. The good news is if your underfunded GP practice that can't recruit any staff closes, you'll no longer be able to phone up at any time of the day to get an appointment. Never fear. Point number 2 on the government website, you can get a prescription medication directly from a pharmacy without a GP appointment. Yes, this is the news about Pharmacy First. £645 million of funding over the next 2 years being pumped into English pharmacies to try and offload appointments from general practice. So now if you've got an earache, sore throat, sinusitis, impetigo, insect bites, a whole range of conditions that you don't need antibiotics for, you can go to your pharmacy and ask them for some antibiotics. We've saved one consultation, we've traded it for another. Expect a phone call a few days later with a patient going, "Doctor, I think I need a different antibiotic because this one's just not working." I actually have quite a lot of faith in my local pharmacy, but unfortunately they are on a knife's edge because pharmacy funding has been cut by 30% over the last decade. So it's not just general practice that has had hollowed out in recent years. The chances are that the local pharmacies are going to really struggle to actually have the manpower to deliver these expanded services. Meanwhile, the larger corporate pharmacies will probably be lapping this up. So when they started being able to do NHS hearing checks, we all started getting leaflets through the door saying, "Do you need a hearing check? Come and have an NHS one in your local pharmacy." They're actually creating the demand because they're going to earn money from it. And I don't know what they're going to get paid with this new scheme, but if it's anything like the hypertension case finding service that was introduced into pharmacies a couple of years ago, where they were paid £15 for a clinic measurement of a blood pressure, £45 for ambulatory blood pressure monitoring, plus additional monies for setting up and maintaining the service. Imagine if general practice was paid by activity and some of that money was coming into your practice. Now, what else is on the list? There will be more GP appointments available to you. Not actually true. And then we have £240 million of funding to help transition from analogue phone systems to digital telephony. Now, most practices probably already have this in place, so this money probably isn't going to make much difference to you, I'm afraid. But for those of you with an old school phone system, just a word of warning, the one thing that pisses patients off more than hearing an engaged sound when they're trying to phone their practice is being put in a queue where you're 50th in line, a never-ending queue that you will never get out of. And the one thing that pisses patients off even more than that is if that call would be picked up, as the government has suggested, by someone in a call centre. Yes, call centres may be coming to GPs near you. The call centres won't be anywhere near you. They may not even be in the same country, but they can still tell you that the lists are full. Please call 111 and you can enter the GP NHS 111 death circle. One of the 7 circles of hell with patients trapped between 2 services and what initially started off as some minor impediment that they could have self-managed ends up in a ruptured aneurysm. The only saving grace here is that by the end of it, one of your family members can legitimately call 999 for you. Okay, onto the research, and we're going to have a look at a BJGP paper first. This whole edition from the BJGP is on COVID-19, very timely as just a few days ago the WHO called off the pandemic. It's all over. Don't worry, kids, it's okay to come outside again now. It was great seeing how this was misrepresented in the media. They say, don't worry, everything's fine. Actually, when you read the details, they say, no, this is still a very threatening, serious condition. It's just we don't think it's going to wipe out the whole human race anymore. So this BJGP paper has the title Prognostic Factors for Persistent Fatigue After COVID-19, a prospective matched cohort study in primary care. So this was looking at the incidence of fatigue after COVID in people who have had mild disease, so they're managed in the community. These are our patients. And then it explored different features in individuals that might make it more likely that you develop fatigue. This data was collected from Dutch general practice with people who were diagnosed with COVID-19 during the first wave, and then they were assessed for fatigue at 3, 6, and 15 months using a tool called the checklist of individual strength. It's not a huge study. They collected information on 179 people with suspected COVID-19 and then compared them against matched controls without COVID. And it's really eye-opening that the levels of fatigue that were reported were just really high. So in the COVID group, persistent fatigue was found in 35%. That's really quite significant. Even in the non-COVID group, I think it's quite high. It was reported at 13%. That's 1 in 8 people having persistent fatigue. What was really interesting was looking at the prognostic factors on who is likely to develop COVID, and the findings are not what I would have predicted. For example, smoking, alcohol use, comorbidities did not seem to be associated with persistent fatigue. Females seem to have slightly higher odds than males, as did overweight or obese patients, but as the authors pointed out, these associations were borderline non-significant. So what was significant? Well, low education level, absence of a partner, high frequency of GP contact, and polypharmacy, having 5 or more medications, had the strongest associations, the highest odd ratios. Also, high neuroticism, low resilience, and threatening experiences in the past also made the list. The authors conclude that these results seem to indicate that psychosocially vulnerable patients are more likely to report persistent fatigue after COVID-19 infection. Now, we need to be a little bit mindful that these are associations, it's not proving causation, and we have to be cautious about the conclusions that you can draw from these data. However, I think that it just reminds us that while we do have a growing evidence base that there are physical, pathophysiological causes for long COVID, things like microemboli, persistent epithelial dysfunction, ongoing multi-system dysfunction, and so forth. And it's great that we've got this understanding, and maybe, just maybe, this could potentially open the door for some treatments for these unpleasant conditions, not just long COVID, but maybe chronic fatigue syndrome as well. While all of this is hugely important, I think this data just serves to remind us that sometimes it's a little bit more complex than purely physical. That is not to say that things like chronic fatigue syndrome or long COVID are all in people's heads. That viewpoint is outdated and wrong. But in a world where we have the placebo effect, or where a person can chop off their own arm, which is trapped between 2 rocks in a bid to save their lives and not really feel it, to fail to acknowledge the influence of the mind on how people feel, and beyond that, how external forces affect the mind, well, that just seems a bit short-sighted. There's one thing that we know in general practice, it's that no symptom, indeed no person, lives in isolation. Okay, complete change in topic now, and we're going to have a look at a New England Journal of Medicine paper, which I thought was really interesting. It's a phase 3 trial, so this is not a treatment which is available just yet, and indeed I dare say that it's not something that we're going to be prescribing anytime soon. Even when it is, it will probably be the remit of allergy specialists. However, I think it's really interesting just seeing how things are developing here. So this is titled The Phase 3 Trial of Epicutaneous Immunotherapy in Toddlers with Peanut Allergy. Allergy growing business, lots of children with food allergies. Peanut allergy is quite common and one of the most common causes of why people will die from anaphylaxis. Immunotherapy then is giving low doses of the triggering allergen to try and build up a resilience to it over time. And this technique has been successfully demonstrated recently with peanut allergy. But what's novel about this research is, firstly, it's been conducted in children who are younger than have been assessed previously. So currently available and approved treatments are in children of 4 years and older. whereas this is in toddlers aged 1 to 3. Secondly, previous research has either involved eating peanuts or taking a capsule containing some peanut allergen. This, of course, is not ideal in younger children, and especially if it's causing a reaction, good luck getting them to eat that again. So this new treatment is in a patch. The study then was a double-blind, randomized, placebo-controlled trial of children aged 1 to 3 who had demonstrated peanut allergy confirmed by a food challenge. And then they received either an epicutaneous immunotherapy, which is a fancy way of saying a peanut patch, or they received a placebo patch, and they administered those daily for 12 months. The primary endpoint was desensitization to oral peanut protein challenge, and the results favoured the intervention. So 1/3 of the placebo group were desensitized by 12 months, but 2/3 of the patch group were. The downside was that every child who received a peanut patch reported adverse events during treatment. In its defense, so did 99.2% of those having the placebo patch. So the vast majority of the adverse events were application site reactions. Maybe they need to think about a slightly different patch. Anaphylaxis was thankfully rare, so 1.6% or 4 out of 244 children on the peanut patch developed anaphylaxis at some point. It was mild to moderate, apparently, which is still severe enough to put me off prescribing. But of course, we're not the target market here. This is not going to be something for GPs to be prescribing. This is going to be something under the remit of the specialist, which still does require careful counselling and monitoring. It does make you wonder if it's worth it, but I guess if 2/3 of this group, who otherwise might get anaphylaxis to peanut ingestion, are desensitized to the point where they can at least have 1 or 2 peanuts, so if they accidentally eat some, then it doesn't kill them. Well, for that group, and also just by removing that fear from the child and their family, that does start becoming pretty significant. Okay, let's stay on the allergy theme, and it's time for our interview now. Just one more thing. Today I'm lucky enough to be joined by Dr Matt Doyle, who is a GP in Jersey. He's an expert in allergy. He's the current chair of the primary care section of BSACI, the British Society of Allergy and Clinical Immunology. Let you introduce yourself.
Yeah, sure. So as you say, I'm a GP based in Jersey in the Channel Islands, which is a lovely place to be. And I started getting involved in allergy about 13, 14 years ago. So as you said, I chair primary care for the BSACI, and I also sit on the primary care board for the European Academy of Allergy, which is the pan-European version of the British Society of Allergy. And I've been very lucky to do lots of fun stuff since I started studying allergy. And, I've sat on a few nice guidelines. So I did the anaphylaxis guideline and the drug allergy one. And I currently sit on the guideline group for the new nice BTS sign guideline for asthma.
Maybe let's start with just thinking a little bit about allergy in general. How is it affecting general practice in our patients?
At the moment, it's become the most common inflammatory disease state in the world. We estimate that by 2025, so 2-3 years from now, about 50% of people in Europe will have some degree of allergic disease. And of course, the majority of that will be allergic rhinitis, hay fever. But we're also looking at food allergy, we're looking at drug venom allergy, we're looking at asthma, eczema, urticaria. These are all falling under the allergic disease umbrella. And unlike other immune or sort of inflammatory diseases like diabetes, where in primary care, we're very good at screening for type 2 diabetes. We're very good at putting in interventions when we find people are in pre-diabetic states, and we know what to do. We know medications we can use to try and reduce their risks, and we know lifestyle interventions we can put in. We're kind of winning the battle there to a certain extent, but we're not winning the battle with allergy at all. A huge proportion of people will be misdiagnosed. Huge proportion of people will find that their treatments are ineffective. Current data is that we lose in the EU Though I'm not sure, can we say we lose in the EU anymore? I'm not sure, but
we lost already.
We lost already, but yeah, we lose about 100 million work and school days every year due to allergic disease. And I think as general practitioners, we're at the absolute knife edge of this.
Maybe let's move on to our questions. First question, as ever, is what do we need to know about in general practice regarding allergy? I'm conscious that's a very broad question.
Well, I think we can do some very quick points. What do we need to know about allergy? Well, if we take allergic rhinitis, intranasal steroid, if it's used correctly, so if the technique is right for using it, is much more effective than antihistamines for people's hay fever. The technique is that people need to have that spray up, head facing the floor approach and not sniff and snort after using the steroid. And we need to tell people that it'll take 5 to 7 days to start to work and probably up to 2 weeks before they really see the effect. If they start that before the season, so if they're grass allergic, if they're starting that late April, early May, they'll probably find that their disease is suppressed a little bit and they can get through the season far better by doing that. Kenalog is not a good thing. Huge dose of steroids, it still gets used quite a bit, but you've got to always have an exit strategy with steroids. If you give someone Kenalog, they're going to be back next year for the next injection.
It used to be really popular, didn't it? You just give people a big slug of Kenalog at the start of the season and then hope they didn't break their hip by the end of it.
Yeah, absolutely. It works. But as I say, you've got to then think about, well, that sorts this season out, but this is a person who's going to come back next season and the season after. We do grow out of allergies, so we do become tolerant to them over time in some cases, but some people will have lifelong symptoms. So we really need better strategies than just whacking people full of quite damaging drugs. Urticaria is a very common thing we see in general practice. I think most people who come to a GP with urticaria have probably been told by somebody along the line, oh, you must be allergic to something. Most, certainly in adults, I would say most urticaria that you see is probably not going to be due to an allergy, particularly when you see people who have relapsing remitting urticaria over weeks and weeks and weeks. Generally, if there's no temporal relationship to exposure to an allergen, then it's very unlikely. Most urticaria is a reaction to a virus or just signs of very healthy, slightly overreacting immune system. It's different if you see a young person and their mum says every time they eat egg within 12 hours they've got urticaria and then it fades within 24 and then doesn't happen again until they get it and they eat egg again. Well, that's different. But I think most people who have urticaria day in, day out for weeks on end, that's probably something that is not going to be allergic in nature. And it can be a challenge to treat. Up titrating antihistamines is still the best way. So giving normal antihistamines off license in doses, maybe up to 4 times a day for something like cetirizine, so 10 milligrams cetirizine up to QDS. So angioedema is just a kind of deeper version of urticaria. They often go together. But again, you do see chronic urticaria people having occasional lip angioedema or sort of other soft tissue angioedema from time to time. Always look out for ACE inhibitors, because they're, particularly with the angioedema patients, they are such a common trigger and it's so easy to miss that. And I think the data is that people who turn up at an A&E department with angioedema because they're ACE inhibitor, up to 10% of them will require HDU or ITU treatment.
And speaking of serious reactions, let's think about anaphylaxis, because this is what worries patients and parents the most, isn't it? Especially linked to food allergies. There's been a lot in the media about that recently. Particularly peanut, but also milk allergy is a problem.
We're seeing more and more anaphylaxis attending hospital or, happening out in the community over the last 20 years, but we're not seeing an increase in fatal episodes of anaphylaxis, which is partially reassuring. And you're absolutely right to mention milk, because peanut, as you rightly say, is sort of the big bad boy of allergy. If there's peanut allergic reactions, it's very common to appear in the newspapers, things like that. But actually persistent milk allergy, particularly milk allergy that goes into adulthood, people have very, very severe reactions. Alongside peanuts and tree nuts, the milk allergy is probably the one we worry about most if we're trying to look at somebody's risk of having a severe reaction or ending up in hospital with a reaction. But the rates are not increasing of fatal reactions.
Do we know why that is? So is that because we're getting better at treating it, or is it because we're seeing more allergy but simply not more life-threatening allergy?
Well, do you know, the fascinating thing is we don't even really understand what anaphylaxis is and why it happens.
At least it's not just me then.
No, it's really complex. You see, because we kind of define anaphylaxis as being multi-system. And when you think about it, if somebody gets stung in the arm by a wasp and they have a severe reaction to that, now they might get kind of involvement of all their skin. They might get sort of itching, redness, urticaria hives, that kind of thing across all their skin. And the skin is, of course, our biggest organ in a way. And you've got to think to yourself, well, how does that happen? Why is suddenly, if the venom is at one site and then suddenly it's affecting all of the body? And then how does it, people get tummy cramps and vomiting, they get wheezing, they get breathing. What's happening in the body to cause this immunological reaction to affect so many parts of the body? So these severe reactions, so anaphylaxis is a multi-system effect. So it's when people, they don't just have, say, effects on the skin or angioedema, they'll have respiratory involvement or hypotension particularly. They might get GI tract involvement. And they can be very variable. So, with drugs particularly, we'll see hypertension as part of the picture. With foods, we can see more respiratory involvement as part of the picture. So it is challenging, but I think importantly, the risk of having anaphylaxis in your lifetime in the UK is probably just over 1,000. But the risk of fatal anaphylaxis is incredibly low.
I think when we're thinking about treating anaphylaxis, we're all on board with the idea about adrenaline auto-injectors these days, and people should have a pair of auto-injectors. I think that message is kind of transferred through most of general practice quite well over the last few years. I think a lot of us still think about treating with antihistamines and with steroids as well. But there's been an updating guidance recently, hasn't there, about what the best kind of approach is, because it's probably not that.
Yeah, you're absolutely right. And the new Resource Council guidance is very clear on that. If we look at the sort of steroids, we look at antihistamines, steroids, there's never been any evidence for steroids being effective in severe allergic reactions. The theory was that it probably helped the later phase reaction. So in the later phase reaction, you've got something happening slightly differently to the immediate reaction immunologically. You've got all these eosinophils being recruited, different cytokines being involved. And theoretically, the thought was, well, if I give someone a hit of either oral injectable steroid, I know it's going to take hours to work, but by the time it starts working, I'm going to be affecting any risk of late phase reactions. Actually, that doesn't appear to be the case. And we do know that people who are given IV steroid are much more likely to get infections. They're much more likely to end up on ITU than the ones who aren't given them. So steroids aren't good. Antihistamines, there's not much evidence they have any benefit. The big problem with antihistamines is they probably delay people getting adrenaline. So I think the key message that the Resource Council has focused on is if you're worried about anaphylaxis, you're going to give adrenaline and you're going to give it as quickly as possible. And I think the other thing that they very much stress in the guidance, which wasn't so stressed before, is about lying people down. You get these amazing changes in people's circulation in anaphylaxis. You get some changes in stroke volume and so on and so forth. So you can have someone who's absolutely fine when they're lying down, and then you stand them up and their blood pressure just drops and they need kind of more intensive support. But lying down, they were managing particularly well. So lying someone down, bending the knees, bringing the knees up, or elevating the knees on the chair to encourage venous return. If they're really having trouble breathing, then you can sit them up slightly, but what you don't want to do is put them in a chair or have them standing up. And then it's about giving adrenaline injectors. I mean, you mentioned about giving 2 adrenaline injectors. You're absolutely right. MHRA are very clear on that. And the reasons are very clear. You might need a second injection after 5 minutes if the reaction's not clinically improving. You might not be sure how to give your injector. You might muck up the first device, accidentally inject your thumb, things like that, or not get the full dose in. And very, very rarely, sometimes the devices fail. But, so having 2 is absolutely crucial. And I think understanding the difference between the 3 available devices we've got in the UK is also important. Historically, we've had this swing and jab approach, this gung-ho, hold the injector and smash it into your leg, with a big arc at speed. And that's a very easy way to miss. So now I think the the advice should be to do what we call a sort of place and push, put it onto the leg and then push it. So have it in position rather than this swing and jab approach. I think one of the other things that's coming out is about giving a second injection into another part of the body. So I think lying down, very, very important. Going straight for adrenaline is very, very important because it's just a top up of our own adrenaline. You're not going to harm anybody by giving adrenaline dose, and giving, if a second injection is needed, giving the injection in another part of the body, so in the opposing leg, is probably not a bad shout. And as I say, understanding about the 3 injectors, because they do have, the main difference is the time you hold them in place. We've got EpiPen, which is 3 seconds. We've got Jext, which is 10 seconds. And we've got Emerade, which is 5 seconds. And it's frustrating that they're not all exactly the same, but they are different devices. They all kind of deliver the same amount of adrenaline in the area, whether you use a Jext 300 mic or an Emerade 500 mic, you're getting about the same amount of adrenaline into the body. The crucial thing is having the device and being able to use it. All the pens have apps, so it's getting a lot easier because now every single pen has an app, and there's 2 great things about the app. One is it's got videos showing how to use it, but the other thing is you can put the serial numbers of your pens into the app and it'll send you text alerts when they're going to expire and when you need to order.
I love it when a bit of modern technology actually helps us. That's really good.
Yeah, absolutely.
I like it. Okay, let's come on to our second question then. So what do we need to know about that secondary care is up to in the world of allergy?
Yeah, I think probably the biggest one at the moment is Palforzia. So Palforzia is a drug people may have heard of. It's a immunotherapy, an oral immunotherapy for peanut allergy. So essentially this is a capsule that contains small amounts of peanut protein, and they're very, very small amounts. I mean, I think the first one is something like under 1 milligram, and a peanut is probably about 200 milligrams worth of protein. So, a whole peanut. So they're very, very small amounts, and it's licensed. So NICE approved it last year. It's licensed to be given between the ages of 4 and 17. And if you start the treatment over 3 years, when you're 17, you can then keep going. You don't have to stop when your 17th birthday rolls in. You can keep going beyond 18. And it shows quite a significant improvement. It doesn't cure the allergy, but it means the threshold at which you'll react gets much higher. So it means that if you successfully complete the treatment and you then go to a restaurant and there's a small amount of peanut that you didn't realize in the food, you're less likely to react than you might have been before the treatment. Palforzia's not, it's a commercial sort of drug product. It's not a new idea. They've been doing it, peanut immunotherapy with actual peanut in both America and in the UK. So Andy Clark and Pam Ewan in Cambridge have been doing it for a number of years. But Palforzia is quite a big breakthrough because it's the first sort of worldwide approved product that's specifically for treating peanut allergy in young people. And it does, the first day you have it, you get up titrated with a number of doses over a number of hours, and people do react. People do have reactions. So it doesn't mean you don't stop carrying your adrenaline injectors when you're on the treatment, because people can have reactions to it. In fact, the number of reactions people have to it in France, they're now kind of black triangling the drug in a new way. So they're slightly worried about whether they continue to use it. They've put a bit of pause on it in France. But it's being used in the UK, and there's quite a number of people who are going through the treatment process since it was put into practice at the end of last year. So it's very encouraging. And
it does seem to be effective. In the research that they've published, it looks like by the end of the treatment course of the studies, compared with placebo, so in the placebo group, around 2.5% of people will have developed some kind of, should we say, tolerance to peanuts, whereas in that Palforzia group, it's over half of them, so more than 50%. So that is pretty impressive figures. But there are obviously limitations as to why this is not a drug for general practice. This is very much a drug for secondary care, isn't it? And part of that is the reactions that people might get, and making sure that people understand how to deal with those reactions. Part of it is the cost as well, because it's an expensive drug.
Yeah, it's about £10 a day, not a cheap option. And I think that's one of the problems in a cash-strapped NHS of how much can it be done. So I think it's much more available privately now than it is through NHS services. But immunotherapy has been around for 100 years. This isn't a new idea. The idea that you can induce tolerance to something that you are having this hypersensitive reaction to.
I know that used to be quite a popular option, trying to do sort of grass allergy immunotherapy. And that seems to have, I mean, maybe it's just my perception, but that seems to have died a little bit of a death. Why are we not using that more when, on the face of it, it sounds like a really good option for a lot of people?
Yeah, I think part of it is cost. So even Grazax, I think the cost is going to be about £80 to £90 a month. That's not an insignificant cost for a drug. Part of it is, I mean, going back to you're absolutely right to say we used to use a lot more of immunotherapy than we do now. So there's two main types of immunotherapy. There's sort of subcutaneous immunotherapy that we'd use in sort of venom, so wasp and bee reactions, and then there's sublingual immunotherapy, which is generally far better tolerated. You tend to get more risk of reactions in people with asthma with subcutaneous immunotherapy. And there was a rash in the kind of 80s, 90s of severe reactions to subcutaneous immunotherapy in asthmatics. So I think that put a bit of a hold on it. But, you know, if you get the right people and you treat them appropriately, sublingual immunotherapy probably should be more widely used than it is, because the problem with hay fever is it's such a huge issue. The cost of it is so colossal and the effect on the economy is so huge. So being able to induce tolerance in someone with grass hay fever would be a really big deal. And most people with sublingual tolerate it very, very well. You know, it's you do get reactions, but they're generally localized reactions. People getting itch, tingling in the mouth, maybe a little bit of symptoms in the throat. It's quite unusual to have severe reactions even in kids. But again, it's not something I would, expect a GP to oversee and initiate. It should be done through specialist care.
Which leads us on to our third question then. What can we expect in the future for allergy medicine? What's pushing the boundaries? And partly, I mean, I'm sort of influencing this a little bit, but are we any closer to a cure?
The problem with allergy is we're looking at such a wide umbrella of different diseases. So we've already talked about immunotherapy for not curing, but, we're inducing tolerance. Fascinatingly, it's still very unclear how we induce tolerance. So when you look at it immunologically, it's not clear at all what's actually happening to make things like Grazax work, but they do work in the majority of people. If we look at other common presentations, we look at, if we take urticaria, for example, there are some very good biologics now available for urticaria, which are also licensed in things like asthma, like omalizumab or Xolair, which is about to go off patent and therefore probably will have more widely available prescribing, certainly in secondary care. And with chronic urticaria, omalizumab is amazing. It really gives people complete remission. They get on with it very, very well. It's brilliant in severe asthma. And then with severe atopic eczema, you've got monoclonals like dupilumab, which is becoming more and more used. And there are some JAK1 inhibitors that are getting licensed in the US and over here for severe eczema. So we've got lots of interesting biologics that target either certain cytokines or target, in the case of Xolair, they target IgE itself, that are massively helping people going forward. As far as curing things, that's the golden sort of multi-million-dollar question, and there's a lot of research looking at that. And part of it is about exposure. We know in the UK, we kind of record holders in the UK on peanut allergy when we look worldwide. It may be that part of that is because we've always advised people to avoid, we've advised pregnant mothers to avoid peanut. We've advised not giving peanut to under 12 months of age. When you look at countries where that's not the advice, where peanut is given much earlier on, you get less peanut allergy. So there are studies looking at early introduction. There are studies looking at whether you can take a number of food allergens in children who are at risk of developing food allergy and start giving them regular amounts of these food allergens from an early age do you actually prevent them developing those food allergies? Almost immunotherapy by exposure of the foods before they become allergic. So that's, I think, an important part of what's coming over the next few years.
Thank you so much, Dr. Matt Doyle. Wealth of knowledge about allergy. Fascinating talking to you today. Thanks a lot.
Pleasure. Thanks very much.
Don't forget to check out all the great things going on with NB Medical over the next few weeks. We have got Hot Topics courses coming up, live webinars on Thursday, the 18th of May and Saturday, the 10th of June. Also, we've got our brand new to General Practice course, which is coming on Thursday, the 15th of June. That's a half day from 9:30 till 1. So if you've got registrars who are just about to complete their training, or if you're a GP in the first few years of training, then this could be the course for you. Do check it out. As ever, you can get in touch on Twitter and email, and we'll be back in a few weeks. Thanks for listening. See you next time. Bye-bye.